A patient walked into my office last month and said, I've been told I need a spinal fusion for my stenosis. Is that really my only option? That conversation happens in my office almost every week. And the answer is almost never as simple as the patient came in expecting. If you've been told you need a spinal fusion for your lumbar stenosis, or if you're trying to figure out whether decompression alone is enough, this video is for you. In the next 10 minutes, I'm going to walk you through the actual difference between a decompression and a fusion, when fusion is the right answer and when it is not, and the specific questions to ask your surgeon when both options are on the table. This is the conversation I have with patients in clinic, the same way I would have it with you if you were sitting across from me. I'm Dr. Omar Ramos. I'm a fellowship-trained spine surgeon at Twin City Spine Center. Decompression is a surgery I do most often for stenosis. Fusion is something I reserve for specific clinical scenarios, and I'm going to walk you through exactly what those scenarios are. Let's start with the basics, because I want to make sure we're on the same page about what each operation actually does. A decompression takes pressure off of the nerves. We remove a piece of bone called the lamina, we remove the thickened ligament behind it, and we make more room for the nerves that have been getting squeezed. That's it. No hardware, no fusion, no screws. Your spine still moves the way it was moving before, just with more room for the nerves. A fusion is a different operation. We usually still do a decompression, but on top of that, we're locking two or more vertebrae together. That involves placing screws into the bone, connecting those screws with rods, and packing bone grafts so that over the following months, the two bones grow into one solid bone. The decompression takes pressure off of the nerves, the fusion adds stability. They are answering different questions and treating different issues. Here's the principle I want you to walk away with from this video. Pick the smallest operation that solves your problem. That's the framework I use with every patient considering surgery for stenosis. Not the biggest operation, not the most thorough operation, the smallest one that actually solves what's going on. For most patients with stenosis, the smallest operation that solves the problem is a decompression because the problem is pinched nerves. So you take the pressure off of the nerves, done. Go home, get back to your life. Fusion is the right answer when there's a specific reason that decompression alone won't be enough. And those specific reasons exist. They're real, and I'm going to walk you through exactly what they are. But fusion is not the default for stenosis. Fusion is an option that addresses a specific clinical scenario that some patients have, but most patients don't. So when is fusion actually the right answer? Let me walk you through the situations where I would reach for a fusion myself, because being honest about that is just as important as being honest about when not to do a fusion. The first and most common situation is instability. This usually shows up on imaging as a condition called spondylolisthesis, or shifting of one vertebrae on top of another. But not every slip needs a fusion. The key question is whether the slip is mobile or stable. If we see significant motion at that level on flexion extension x-rays, that's a mobile slip or unstable slip. In that situation, decompression alone has a meaningfully higher risk of destabilizing that segment further. So in most of those cases, we decompress, but we also fuse. For a stable grade 1 slip, especially in a patient whose primary problem is leg symptoms and not significant mechanical back pain, decompression alone is often enough. The slip is there, but it's not behaving in a way that requires us to stabilize it surgically. The second situation is significant spinal deformity. If your spine has a meaningful curve, a scoliosis or kyphosis, that's part of the problem. Addressing the stenosis without addressing the deformity often doesn't get you where you want to be. Those cases sometimes need a fusion to actually correct what's going on structurally. The third situation is when the decompression itself would need to be so wide or so extensive that it would destabilize the segment. This is technique dependent and case dependent, but the principle is, if to free the nerves, I have to remove enough bone that the spine is no longer stable afterwards, I have to add a fusion to make up for that. And the fourth situation is a specific type of recurrent stenosis where you've had decompression before, the symptoms have come back, and the revision surgery would require enough bone removal to risk a fracture or again destabilize that segment. That's a relative indication for fusion. Recurrent stenosis on its own is not an automatic fusion indication. It's only when the revision decompression itself would compromise the stability of the spine so that fusion becomes part of the conversation. But I'm hoping you can see that the decision to include a fusion is very nuanced, and it doesn't mean that just because you have stenosis and you need surgery, a fusion needs to be considered. Here's why this distinction matters and why I'm so deliberate about which patients get a fusion and which patients don't. Fusion is a bigger operation. Bigger incision, usually longer surgery, more blood loss, longer recovery, higher risk profile across the board. That's not a reason to avoid it when it's actually indicated and needed, but it is a reason not to do it when it's not absolutely necessary. There is also something we call adjacent segment disease. When you fuse two vertebrae together, you change the biomechanics of the spine. The motion that used to be distributed across that segment has to go somewhere, and it tends to transfer to the level above and below the fusion. Now, whether that actually causes new problems or whether those segments would have aged the same way regardless of surgery is generally debated in spine medicine. Spines keep aging whether we operate or not, but the honest answer is we change the biomechanics, so we cannot say that fusion does not add to that risk. Adjacent segment disease may happen, and a fusion may be part of why. That's not a reason to refuse a fusion when it's the right answer. It's a reason to make sure it is the right answer before you sign up for one. So let's bring this back to the practical question. If a surgeon has recommended a fusion for your stenosis, here are the 4 questions I would ask in your next conversation with them. Question 1, why fusion instead of decompression alone? Have them walk you through the specific clinical reason. If the answer is instability or spondylolisthesis with dynamic motion or significant deformity or the decompression would destabilize the spine, those are clinically valid reasons. If the answer is more vague, just to be safe or to make sure it doesn't come back, that's worth a longer conversation and possibly a second opinion. Question 2, how was the instability assessed? The way we actually look for instability is by comparing your spine across different positions, flexion extension x-rays, where you bend forward and backward, comparing to standing x-rays and your supine MRI. MRIs are usually done laying down, which means they don't show what your spine does under load. Only by comparing those different positions can we see whether the segment is actually moving in a way it shouldn't. There are also some subtle findings on MRI that may make you more prone to have instability. If a fusion is being recommended for instability, that instability should be documented on the right kind of imaging. Question 3, what does the recovery look like for each option? Decompression alone has a meaningfully different recovery than a fusion. If you understand both, you can decide which one fits your life and your willingness to tolerate a longer recovery for the right indication. Question 4, what's your reasoning for recommending one over the other in my specific case? Not in general, in mine. A good surgeon should be able to walk you through the specific reasoning for your imaging, your symptoms, and your situation. My personal approach, as I evaluate a patient, I tell them what I'm thinking through and how I come to a decision, so at the end, we're both on the same page. None of these questions are confrontational, they're just clarifying, and you're just trying to understand your condition. Any surgeon worth your trust will be happy to answer them. At the end of the day, what we're trying to figure out together, me and the patient, is which operation is most likely to give you your life back with the least amount of risk and without doing more than is necessary. The smallest operation that solves your problem. For most patients with stenosis, that's a decompression alone. For some patients with specific clinical indications, that may be the decompression with the fusion. And the difference matters. It's not about which operation is better, it's about which one is the right one for you. If a fusion has been recommended to you and what I've described in this video has raised questions for you, get those questions answered, either with the surgeon who recommended it or with a second opinion. Both are reasonable paths. And if you're in Minnesota or the Midwest and you'd like to have that conversation with my team, the link in the description is how to schedule a consult. We'll review your imaging, walk through what's actually going on, and help you decide if and which surgery may be the right answer for you. Always from a framework of risk versus benefit. This is video 5 of 5 in the Lumbar Spinal Stenosis series. If you've watched all the way through, thank you. The full series is linked in the description in order. If you found this useful, send it to someone who needs it. I'm Dr. Omar Ramos. Take care of yourself out there, and I'll see you on the next one.